Good afternoon, and welcome to this interprofessional in-service lunch and learn presentation on diabetes type 2. My name is CathyAStephens, and I'm a registered nurse here at DHRA, and I'm a care coordinator on the DASH development team, which is a newly formed team to increase compliance and assist individuals affected with diabetes. I want to thank you for spending your lunch with us. We have provided a lunch that is reflective of what we would encourage our diabetic clients to eat for a typical meal as we promote healthy eating that can be both nutritious as well as tasty. The objective of this presentation is to give healthcare professionals a better understanding of type 2 diabetes. I will focus on pathology of the disease and the criteria that leads to a diagnosis, a discussion of the 12 classes of drugs to treat diabetes, non-therapeutic measures for treatment, and the outcomes of care for these individuals. At the end of the presentation, I am hopeful that you will gain a better understanding of type 2 diabetes by being able to describe the pathophysiology and some predisposing factors, be able to discuss at least 2 symptoms that occur, and name 2 medications that are used for diabetes and a side effect or 2. Also, you will be able to name 1 or 2 non-therapeutic methods for treatment, and lastly, be able to state 2 health promotion and risk reduction activities and goals for care. There is no test after the presentation, so relax and enjoy your lunch. I have put a fast-backed handout at the back table as well as an evaluation of the presentation. Let's start by discussing the problem of diabetes. Type 2 diabetes is a worldwide epidemic. In fact, according to the CDC, this disease affects nearly 30 million people. And even just as concerning as that is the statistic, also by the CDC, that this disease is undiagnosed in 27.8% of the population. To put that in perspective, there are roughly 30 of you here at this in-service, which means that 8 of you most likely have undiagnosed diabetes type 2. If we as a society do not engage in risk reduction measures to control this disease, it is estimated by Mertag that by 2025, 1 in 3 adults will be diagnosed with diabetes type 2. There are predisposing factors that can influence the likelihood for having type 2 diabetes. Genetics is thought to be a factor as well as ethnicity. The prevalence is higher in Hispanics and African Americans, with those ethnic groups having double the incidence of diabetes as compared to Caucasians. The Native American population is the ethnic group with the highest rates of diabetes, which is 2.5 times incidence compared to non-Hispanic Caucasians. While you can't control your genes and ethnicity and your age, which age is also another predisposing factor, diabetes increases after the age of 45 and will affect 25% of the population of 65 years and older by 2050. The American Diabetes Association has a document that is basically the Bible for care of patients with diabetes, both type 1 and type 2. The main goals that they have outlined in the care of the type 2 diabetic individual are glycemic control, nutrition therapy, and blood pressure control. Glycemic control is the regulation and maintenance of blood glucose levels within normal range, which can reduce secondary complications. Nutrition therapy can be one of the most challenging part of any treatment plan. The ADA's position is that there is not a one-size-fits-all eating pattern and recommends that each individual be involved in nutrition planning. This necessitates that the healthcare team is knowledgeable about nutrition therapy for individuals with diabetes and specific nutrition recommendations. Blood pressure control is extremely important to mitigate the risk of individuals with type 2 diabetes succumbing to the serious complications of atherosclerotic cardiovascular disease. According to the ADA, there is evidence that the leading cause of mortality and morbidity for individuals with diabetes is atherosclerotic cardiovascular disease. Managing the disease and preventing complications is a goal for individuals with type 2 diabetes. Bronfenbrenner has an excellent model that provides a framework to guide health promotion and risk reduction interventions that increase the likelihood for success. The socio-ecological model provides a framework and takes all contributing elements into the equation, such as the individual needs, as well as how influences from society, community, and even factors such as policy affect behaviors. The ADA states that diabetes is a chronic illness that requires continuing medical care and ongoing patient self-management, education, and support to prevent acute complications and to reduce the risk of long-term complications. According to Mertag, through 2012, One of the most important impacts that nurses and healthcare professionals can have on any individual is to teach them how to promote their own health and prevent illness. Diabetic self-management education should include instructions on blood glucose levels, medication, nutrition, exercise, symptoms of hyper and hypoglycemia, routine exams such as eye and foot exams, and the need for regular checkups. You can help individuals with type 2 diabetes by assisting them with encouraging them to achieve the highest level of optimal health and coping skills possible. Stress reduction is important as stress can exacerbate glucose levels and can trigger diabetic ketoacidosis, requiring emergency treatment and hospitalization. Education for stress management and coping skills can be provided not only to individuals with diabetes, but also to their family. Teaching personal skills and healthy behaviors to reduce the risk of complications from diabetes is an essential component in health promotion in the diabetic population. So let's talk about pathophysiology. Insulin resistance is the major pathophysiological process that causes type 2 diabetes. Pancreatic insulin deficiency, to a lesser degree, is also involved in pathogenesis. The insensitivity of body cells to insulin causes the pancreas to attempt to compensate by secreting increasing amounts of insulin. Greater than normal amounts of pancreatic insulin are required to produce a normal biological response, causing the pancreas to overwork. Eventually, the pancreas becomes exhausted and cannot continue to secrete insulin in amounts commensurate with glycemic levels. Blood glucose levels climb as the pancreas dysfunctions and cell continually resists insulin. There is no immunological damage of the pancreas, and the exact cause for insulin resistance is unknown. Beta cell destruction occurs as a result from inadequate glucose sensing to stimulate insulin secretion, and elevated glucose concentrations remain unchecked. Over time, isolate beta cell compensation for the insulin resistant fails, resulting in a progressive decline in beta cell function. This decline in the beta cell leads to a decrease in insulin levels. Even after diagnosis of type 2 diabetes, beta cell function continues to worsen, such that people progress from needing changes in diet and exercise only to requiring oral hypoglycemic agents and eventually insulin for an achievement of adequate glycemic control. Future therapies will be directed not only to achievement of glycemia, but also changing the course of the disease by reversing the process of beta cell failure. Obesity is a major contributing factor to the development of diabetes type 2. Fat cells are particularly resistant to insulin. The greater the adiposity of an individual, the greater the insulin resistance. Of importance to discuss is also the effect of a constellation of disorders that is termed metabolic syndrome. Type 2 diabetes is correlated with this disorder. Persons with metabolic syndrome have hypertension, dyslipidemia, hyperinsulinism, centralized obesity, meaning increased abdominal fat, glucose intolerance, and a predisposition to type 2 diabetes. Metabolic syndrome increases the risk of coronary artery diseases and other diseases related to arteriosclerosis, such as stroke and peripheral vascular disease. 50 million Americans are affected with this disorder. Here is a good representation of the multiple and complex pathophysiological abnormalities associated with type 2 diabetes. Many organs contribute to a piece that all leads to hyperglycemia. Symptoms of type 2 diabetes are similar to those that occur in type 1 diabetes. Polyuria, excessive urination, polydipsia, excessive thirst, and polyphagia, excessive hunger. These classic symptoms occur because of the same pathological process as in type 1 diabetes. The development of hyperglycemia caused by deficient insulin action. Hyperglycemia causes intracellular fluid shifts, resulting in polydipsia, and excess diuresis at the kidney that causes polyuria. With lack of glucose entry into the cells, cells sense starvation, resulting in polyphagia. The three blood tests that are utilized for diagnosing diabetes are the A1C, fasting plasma glucose, and the oral glucose tolerance test. The A1C test measures the average of the blood glucose levels over a 2 to 3 month period. The physiology that explains this measurement is reflective of the average glucose saturation that has attached to hemoglobin in the bloodstream. Since red blood cells have a lifespan of 3 months, the A1C reflects an average of the glucose level over a period of time. This test is useful in the diagnosis of diabetes type 2 as well as individuals who are considered pre-diabetic. Fasting glucose level measures the amount of glucose in the bloodstream at the time that the blood is taken for analyzing. This measurement of glucose in the bloodstream aids in the diagnosis of diabetes when levels of glucose after fasting are 126 mils or greater. The oral glucose tolerance test is useful in the diagnosis of both diabetes and prediabetes. This test can be diagnostic in gestational diabetes in pregnant women. The glucose tolerance test is a measure of glucose in the blood after the consumption of 75 grams of glucose. The glucose level is checked after fasting and again after 2 hours after ingesting the glucose. Normal results are below 140. Other lab tests that are useful in examining whether an individual might need further testing include BMP, BUN, creatinine, urinalysis for glucose, protein, acetone, proteinuria, and microalbuminuria. Criteria for assessment is individuals over 45, overweight or obese individuals, and anyone who exhibits symptoms such as polyuria, polydipsia, and polyphagia. Dizziness and excessive fatigue are also symptoms that can be exhibited. Diabetes is a chronic illness that requires continuing medical care and ongoing patient self-management and education to support and prevent acute complications and also to reduce the risk of long-term complications. Glucose monitoring is an essential component to assess if medication and lifestyle changes are effective. Since diabetes care is complex, it requires many issues beyond glycemic control to be addressed. Evidence-based guidelines can direct nursing care in the management of diabetes type 2 and should include medication management, self-care, and health promotion. Regular assessment by their care provider, including eye and feet exams, are essential because the ADA has identified that 60 to 70% of all individuals with diabetes have some form of nervous system damage. Foot ulcers from neuropathy of the lower extremities are a major concern for individuals with diabetes and necessitate a complete foot exam at least yearly. Individuals with diabetes should also be screened for any psychosocial problems such as depression, poor coping skills, anxiety, and stress. Individuals with diabetes might also have stress related to the diagnosis of diabetes and the resulting lifestyle changes that the disease imposes on them. An assessment of financial resources and the ability to pay for diabetic medication should also be warranted. A social assessment should be done on any individual experiencing a chronic health condition, as many social aspects affect the health promotion and management of the disease. Factors that should be assessed are lifestyle, social disparities, economic status, and support systems. A spiritual assessment is also important to identify individual spiritual preferences as well as faith and spiritual traditions that could impact care caused by beliefs. An individual's belief system can also assist in coping with disease and its treatment and provide an avenue for acceptance and healing. Holistic therapies encompass both pharmacological therapy and non-therapeutic. Healthcare professionals should be familiar with the major glucose-lowering drug classes, including insulin, to manage patients with type 2 diabetes. Glucose control is the mainstay of therapy in these patients. In recent years, a variety of new medications with novel mechanisms of action have been approved for the treatment of type 2 diabetes. While this provides more options for the treatment of these patients, the wide array of medications can lead to confusion as to which agent should be used. In general, the ADA and the American Association of Clinical Endocrinologists recommend that in addition to lifestyle modification, metformin, which is a bigunide, is the first line for the treatment of type 2 diabetes for most people. For people who fail metformin therapy, a broad variety of agents can be used in combination with metformin. The choice of second-line and third-line agents varies based on the patient characteristics, patient preferences, and properties of the medication, such as the risk of hypoglycemia and weight gain. This is a good representation and overview of anti-hyperglycemic drugs for patients with type 2 diabetes and are targeted at one or more of the pathophysiological abnormalities of the disease and main sites of action for the 12 drug classes. Combination therapy has become the strategy for those who don't respond to metformin. Holistic therapeutics, non-pharmacological measures to mitigate the effects of type 2 diabetes include exercise, diet, and measures to reduce stress and increase relaxation. Although research has not positively correlated some of the non-pharmacological holistic treatments with lower glucose levels, they can aid in effects such as improving sleep, improved digestion, lower stress, which does lower glucose levels, and an increased sense of well-being. There is an increasing emphasis on patient-centeredness in chronic disease management. This has been described by the Institute of Medicine as providing care that is respectful and responsive to individual preferences, needs, and values, ensuring that patients' values guide all clinical decisions. Shared decision-making is a key component of patient-centered care. This is important in conditions like diabetes that necessitate patient involvement in lifestyle changes. Glycemic targets and blood glucose lowering therapy should be individualized based on a variety of patient and disease characteristics. Each member of the healthcare team is a valuable member, working in conjunction with diagnosed individuals and their family members to promote and maintain a healthy and productive lifestyle. It is with full understanding of the pathophysiology of the disease process, implementation for health measures to effectively manage the disease, care coordination, and collaboration with all members of the healthcare community, including the individual with diabetes type 2, that quality and cost-effective care will be rendered. I have concluded my presentation on diabetes type 2. Some key points that I would love for you to take away are that diabetes type 2 is an epidemic that affects 30 million people. Although there is genetic factor, many other factors can predispose an individual for type 2 diabetes, including race, ethnicity, age, lifestyle, and obesity. Glycemic control, nutrition therapy, and blood pressure control are all goals delineated by the American Dietetics Association for the care of the diabetic individual. There are many health promotion and risk reduction measures to manage the disease and prevent complications such as diet, exercise, smoking, cessation, routine screenings, education, and stress reduction. Diagnostic data includes several blood tests, but the gold standard is the hemoglobin A1C. Non-pharmacological treatments may include diet, medication, prayer, yoga, massage, tai chi, and supplements. And most importantly, a collaborative approach with the patient being at the center of the care is recommended. Thank you for your attendance. I hope that you have enjoyed the presentation and understand why we did not serve cookies and cake for dessert. Be sure to pick up a fast fact sheet and to fill out an evaluation of the presentation. Thank you again, and may your lives be healthy, happy, and balanced.